is out, and I think Catherine's gonna be here. I see you there, Raj, and you're gonna speak today, right? Yeah, all right. I'm excited to hear what you've got to share with us. So we'll give it a couple minutes. Is there, I think Ryan, I think you might be the only one we don't know. And then Anna, I think, are you presenting with Raj? Ryan, have you been on these meetings before?
No, I just recently was selected to be the CRC for Tucker, Preston, Randolph, Mineral, and I know I'm missing one county, Preston.
I get it.
So I actually don't start until tomorrow, or actually Monday morning, but I'm going ahead and try to jump on the call today to see what I can learn here.
Okay. So basically, you know, the REACH initiative and the West Virginia Reentry Councils, we are all things reentry in West Virginia. So we have a couple different programs. Terry is one of our navigators. So people with lived experience work with people as they're coming out to help them navigate barriers and get to the next steps of housing, employment, education, whatever it is they need. So and then we have backpack programs. We have a new community healthcare worker program that's starting. So lots of different things for a very small group of people. But we can do a quick round of introductions of what everybody is and what we do. So I'm Krisha Spears. I do the 21 different reentry councils. So Ryan, if you haven't joined other ones, because you mentioned other ones, I'll drop it in the chat and you can go in and sign up for any of them, and then you'll receive an email the week prior to, and then the morning of, with the link for the meeting. So like this one, you know, if you want to save this to your calendar, this is going to be the same link for the rest of the year for Potomac Highlands.
Okay.
Each council has a static link, and so it'll be the same for each meeting for them. But that's me, and you know, I do all the behind the scenes stuff for the REACH. So writing the grants right now, I'm trying to bulk order stuff for Amazon Prime Day for our backpacks. So social media events, I don't know, I'll do all of that stuff. So I'll pass it over to Terry and she can introduce herself, and then you can pass it off to somebody else.
Hello, my name is Terry Castle. I'm a Reach Back Navigator with the REACH Initiative. I basically, as she said, help people navigate actual life once they're free from prison, which can be challenging. I work with parole officers, I write letters to the parole board, I help individuals, I try to help them, guide them, I try to be a role model for them, which sometimes works out, other times does not. But you know, I just keep on the good fight and try to reduce recidivism. And I will pass it on to Anna.
Hi, I'm Anna Lear. I'm the SUD coordinator for Potomac Highlands Guild. I'm also a contract therapist at Potomac Highlands Regional Jail. Raj.
Hey, I'm Raj Masih. I work as the lead coordinator for the West Virginia Office of Drug Control Policy through Potomac Highlands Guild. Person in long-term recovery and grateful beneficiary of reentry programs.
Jen?
Hi, everyone. My name is Jen Cobb. I am the outreach coordinator for the Northwood Health Systems Crisis Units. We're located in the Northern Panhandle and Wheeling and Weirton. We have 16 beds at each of our facilities, and we can admit for substance use disorder and also mental health crises. We are a voluntary short-term stay, about 5 to 7 days. And our goal is to stabilize the patient and then send them either to a longer-term treatment or outpatient services. Ashley?
My name is Ashley Lowe. I am the reentry coordinator with the U.S. Attorney's Office in the northern part of the state, and handle the northern 32 counties. And really a lot of what my job is connecting folks with different resources. So I jump on this, learn about everything that you all do. And I apologize, I was on the phone, so I don't know who hasn't contact. Tricia, can you help me with that?
Your audio is super low. You sounded better at home the other day. When you said that, I was like, she sounds better at home than she does in the office usually.
I'm gonna talk really, really loud. Does that help?
Yes.
Okay. I was on the phone, so I don't know who has not announced
Oh.
or who has introduced themselves. Can you help me with that?
Yeah, well, Ayla.
Thank you.
Hi, everyone. My name is Ayla Matthias, and I work with Aetna Better Health as a part of their social determinants of health team. I cover the top 32 counties, which is too many counties. So I'm kind of here, there, and everywhere, but I support community organizations and helping them meet the basic needs of their participants.
Thank you.
Has Barb gone?
I'm Barb Fortner, and I work with Tell Them On in Moorfield. And this is the first, I have only been here about 4 or 5 weeks. And my program manager sent me this email about 45 minutes ago and said attend this meeting. So I'm just going to listen and learn at this meeting.
Thank you, Barb. And then Ryan, you said you start tomorrow, but is there anything you want to share about yourself or?
No, nothing real particular today. I mean, I've been with the DCR now, coming up on 13 years. This is my first opportunity to move outside of actual facility and into the aftercare. So I'm really looking forward and I'm very excited for the opportunity.
Right, well, welcome Barb and Ryan. I put over in the chat the link so that you can register for any of the councils. It just takes you to a form. You just fill that out. You can choose any or all the councils that you want to join and list. And all of them, pretty much all of them are remote and like this. Parkersburg does hybrid in Harrison County. Clarksburg, they do remote. So. Great. Jay Simmons, you want to introduce yourself? And then anyone that hasn't, if you can put your contact information over in the chat so we can reach out
It's
to you.
Ashley again. Can you hear me a little bit better? No.
What, Ashley? No. Great. Well, Raj, I will turn it over to you then. Do you need share screen?
Yes.
All right, I will make you co-host. All right, sir, you should be co-host.
Can you see this?
Yeah.
Okay, so basically the genesis, I was asked to present this by Eric Bukowski, the chair of this council. And this is something that we've been working on for about 4 years now. And really, if you look at the transitional period from either incarceration into the community or from residential treatment to outpatient treatment or outpatient treatment back into the community, these transitional times are times of tremendous vulnerability for participants, as you guys all know. And there's a high sort of predicament for relapse, for overdose, for being vulnerable to stress, anxiety, and depression. And so we've been working on this project for multiple years now in various iterations, and I just wanted to give an overview of kind of where we are, what we're doing. We have a Russ Hedrick Recovery Resource Center. I know some of you are familiar with that. In that we have a Christmas tree in a corner, and on the sort of branches of the tree there's multiple little white hearts. And these white hearts have names on them, and these are names of people who overdosed, who were close to our recovery community over the years. And this is just full of these white hearts that are tied to the tree branches. And, all of us know that there have been, people who we know that maybe you're a therapist, you've been working with, you see them every week, you see them on a Friday, and you're like, okay, everything's going good. We'll see you next week. And then on Sunday night on Facebook, we see the person died of an overdose. And we're like, what happened? What happened? Was there something we could have done? And so much of, treatment for substance use disorder is, really based on this episodic treatment, unlike a person with, heart disease or COPD or something who was monitored continuously. So I had tremendous interest in looking at, can we develop some type of monitoring system so that when someone's getting into distress or decompensating, can we intervene? And so really that was the genesis of this idea. And, many of you wear wearable devices like a Fitbit or an Apple Watch that tracks your activity. And the science behind this is based on very similar principles. And so I'm going to discuss kind of what this is. We just presented this at a conference in San Diego last week. So this is kind of a version of that scaled down. But essentially, this is what's happening with my clicker not working. How come I can't change slides? Yeah, do it like this. I'm gonna have to get some help in here. I can't change my slides.
Can you do the click on slideshow? Oh, where'd he go?
I can't change slides.
He's gone.
Can you click on slideshow up at the top if that will?
I can't even see that.
Oh. Your cursor's moving. Yes. So this is our our project is harnessing wearable technology and remote patient monitoring for SUD and mental health. And this is of tremendous interest to people who are in reentry. So what is our device, our BioPatch, which goes on your chest, with a machine learning based analytics engine, which monitors heart rate variability, heart rate, respiratory rate, GPS, and activity through an accelerometer. This is kind of what our system looks like at a high level overview. So we're able to, through physiologic sensors, detect vitals, blood pressure, heart rate, respiratory rate, temperature, behavioral sensors, physical sensors, and communication with peers. Right now, we are in the midst of doing a pilot demonstration project. Our goal is to try and elicit the success of using this on 100 patients with substance use disorders, mental health disorders who are in early recovery or reentry. And so far, we have data on 42 patients. And our objective was, can we use a device to track these physiologic signs, which are known indicators of decompensation? Number two, can the platform send an alert to an assigned peer recovery coach in response to decompensation? Number three, can the peer recovery support specialist communicate directly with the participant and say, yo, what's going on, and try and do an intervention?
And number 4, are the participants open and willing and to accept the alternative strategies and motivational interviewing techniques the PRSS use, and can we make a difference? So that was kind of what we set out to look at. So when we programmed this, we set the bio patch with, so this is, we have a patent on this system. And so we set the parameters to be, heart rate more than 150 or less than 45, respiratory rate greater than 35 or less than 8, heart rate variability, a 50% reduction from baseline. Our system also tracks your GPS location. So if you overdose on a park bench somewhere, we can send EMS right to you. And temperature variability also, because this has a xylazine, as all of you know, causes increased core body temperature. So this is kind of how we set it up. And we have an escalation schema. So Anna is on here. She's the SUD coordinator for Potomac Highlands Guild. So there is a direct pathway. If something is outside of the scope of practice of a peer recovery support specialist, they need a therapist, they need a counselor, they need a physician, they need EMS. So we have all these built-in escalation schema. All of the participants signed a consent form for us to, collect this data and refer to a therapist or counselor if needed. So our system essentially has 3 parts. The first, at the top arrow, you can see speech pattern recognition. So the device connects through Bluetooth to a cell phone. The cell phone then streams the data to an analytics engine, which uses artificial intelligence and machine learning to learn your baseline. Within 4 hours, it learns your baseline, and it can start to not only detect deviations, but start to predict them also. The more it learns you, the more it can predict decompensation. The cell phone that the peer uses to call that person is embedded with a software program that uses speech pattern recognition. So it's not what you say, it's how you're saying it, how the person is speaking, their rate of speech, the emphasis they put on words, and sort of their energy level in speaking. So the speech pattern recognition software built into the phone can tell us whether the person is in high, intermediate, or low likelihood of experiencing anxiety or depression. Many times, if I were to call Krisha and say, Krisha could be having the worst day of her life. And if I call her and say, Krisha, how are you doing? She's likely going to tell me I'm doing fine. So this is an additional layer of protection that can open the door for further conversation with the participants. We also, through the patch, we track heart rate variability, respiratory rate, and temperature. We also have geofencing and GPS tracking. The geofencing is useful for, as we say in recovery, people, places, and things. Don't go to those places that were triggers for you before. If this High Street Morgantown is a trigger area for you, don't go there. So if we geofence that area based on what the person has told us, this is where I used to cop dope before, and he enters that geofenced area, the peer will get an alert on their phone. It can call them and say, yo, what's going on? Get out of there, be safe. And then we have the escalation protocol. So heart rate variability is a marker of autonomic nervous system dysfunction. That's the whole basis of these fitness trackers. And there's a ton of published literature, not by us, but through many, many large medical schools and scientific organizations, showing the direct relationship between heart rate variability, stress, anxiety, depression, and drug cravings. So we calculate the heart rate variability through a metric called the root mean square standard deviation of HRV. And drug use and withdrawal can affect vital functions regulated by the autonomic nervous system. This is a quick overview. The sympathetic is fight or flight. Parasympathetic is rest and digest. And so we can measure these things through this device, and the system can detect them and send alerts. So looking at heart rate variability, what is it? Essentially, if I put you on a cardiac monitor and you're in the ER, and it'll show your heart rate is 72 beats a minute. Reality is there is each beat to beat, beat to beat has a variability, has a difference. The higher your HRV is, the healthier you are. The lower it is, the more likely you're in some form of distress, and we can capture that. So just an idea of, you know, the low versus high HRV, why it's important. This is what our device looks like. It's a bio patch. It has an adhesive side to it, which sticks on your chest. And it's connect through Bluetooth to the phone, which we give each participant, which then streams the data through the cloud to the analytics engine, which synthesizes the data, determines decompensation, and can automatically generate an alert to the peer recovery support specialist assigned to each patient. This is what our dashboard looks like. No names on here, but just showing the types of things that we collect, and, you know, the peers put in sort of what they're finding. This is at a large scale. This is what somebody's tracking looks like: respiratory rate, heart rate. We can see a lot of fluctuation in heart rate variability. Temperature looks very stable. This is what we see on our end on at the analytics engine level. So the monitors autonomic nervous system dysfunction. We track HRV, heart rate, respiratory rate, and early signs of overdose that can prompt immediate interventions. So this advanced capability analyzes specific physiologic markers to detect various types of drug relapses and ensures rapid intervention. This is an example of a patient who was experiencing cravings and had 4 hours of cravings. So you can see the red dots where HRV dropped significantly from their baseline, and we were able to intervene. How can we detect stimulant relapse? So as you know, all stimulants cause elevated heart rate. If we see that there's not a lot of movement going on, for example, if I go for a run, I run for 3 miles, my heart rate may go up to 172, but it will correlate with the movement. So if we don't see a lot of movement and we see an elevated heart rate, that could be something that would suggest stimulant relapse with methamphetamine, cocaine, and PRSS can quickly respond and get that person squared away. This is an actual methamphetamine relapse, what it looks like in real time. So this person, we can see a significant increase in the heart rate from baseline. Turned out this person had relapsed on methamphetamine, and we were able to redirect them back into treatment. We can detect opioid relapse. How do we do that? Through decreased respiratory rate, decreased heart rate. We know that slow, shallow breathing and lowered heart rate are key indicators, and the Crave Alert can identify these patterns to prevent potential overdoses. And the PRSS, getting the alert, can provide immediate support and medical professional help if needed. We can detect xylazine use, relapse, or overdose because it causes significant reductions in respiratory and heart rates and elevated skin temperature. And we've been able to show that PRSS can link that person to treatment. We can also detect anxiety, depression, and stress. So if you were to reverse engineer an overdose. And this is absolutely true, overly simplified. An overdose is preceded by a relapse. Relapse is preceded by either cravings for drugs, stress, anxiety, some kind of life event that caused decompensation. So we are able to very early on track those anxiety, depression, and stress through heart rate variability, respiratory rate, and subtle changes, as I mentioned, from the speech recognition software. And this allows for immediate support and proactive management. We can detect anxiety because obviously anxiety is associated with a persistent fight or flight response. Hyperventilation is common, increased heart rate is common. We can detect that, send a signal to the peer. We can detect depression. A ton of published literature showing that physiologic markers of depression include decreased HRV, lowered heart rate, and irregular breathing, shallow or irregular breathing. We can detect this, and the PRSS can intervene and provide support. We can detect stress. So chronic stress is linked to prolonged sympathetic arousal. This can cause a persistent baseline elevated heart rate, rapid or shallow breathing. We can detect this and we can respond. And if you look at this comprehensive monitoring for effective relapse, so we can do early detection, we can do continuous monitoring, real-time intervention, which overall improves outcomes. So the advantages of this is that it provides 24/7 oversight of these parameters. So when we talk about, you saw this person on Friday and said, okay, I'll see you next week, and he overdosed on Sunday. Well, now we have a window. We have a live, active window into their behavior over the weekend, after hours. This is 24/7. And I'm so proud of our peers. They are answering the phone to alerts at 4 a.m., 1 a.m., 3 o'clock in the morning, 5 o'clock in the morning. So they are taking this very seriously. And obviously this improves patient outcomes. This is something we are looking at doing, is harnessing this system for youth mental health. I mean, the people who are overdosing today, 10 years ago, were youth with mental health disorders. And if we can intervene right now, we can provide tailored support and timely interventions. So some of the key advantage of this is that we can detect subtle physiologic changes for mental health, and we can have proactive intervention. This is something we're looking at doing. Suicidal ideation among youth is huge, especially in our state. And so there is, again, a lot of published literature showing the correlation and the association between heart rate variability, heart rate and activity levels, and suicidal ideation. So a person who's at risk for suicidal ideation could wear our device and be closely monitored like this for timely support. This could be utilized for eating disorder management. So again, every single sort of addiction, whether it's a process addiction like gambling addiction, porn addiction, substance use disorders, or even eating disorders, go through kind of the same common path with the nucleus accumbens in the brain, which is regulated through the autonomic nervous system. So we can detect these things and provide early support. We have not done this yet, but this is on our horizon that we want to do. Again, PRSS trained in youth mental health could offer coping strategies and have escalation protocols. If it's beyond their scope of practice, refer to ANA, refer to a physician, and it can enhance the overall mental health support for youth. So a lot of monitoring that happens in the real world is episodic. So the advantages of ours, it is continuous 24/7 with early detection and timely support. If you look at chronic pain, many people who are current have opioid use disorder. They started with a painful condition. They started with chronic pain that was untreated. They ended up either being prescribed opioids or turned to self-medication through street drugs. So that is always a risk factor for relapse in people with opioid use disorder who have chronic pain. So this has been well described in the literature. And the challenge is, because it is so prevalent, we a lot of times treat the opioid use disorder, but not the chronic pain. And pain flare-ups can lead to the individual self-medicating with street opioids, increasing relapse and overdose risk with all the prevalence of fentanyl. So the Crave Alert system can detect this and help manage through peer interventions. So flare-ups of chronic pain, if I were to check Ashley's blood pressure right now, it'd probably be 120/70, and her heart rate would be 72. But if I hit her hand with a hammer and checked it 5 minutes later, her blood pressure would be 220/150, her heart rate would be 150. So this is well described that flare-up of chronic pain is manifested through elevated heart rate, rapid breathing, and reduced HRV. So we can track these, we can monitor them, and we can provide early support and management. So these are some of the things that we utilize for chronic pain management. Our peer interventions can include things like suggesting relaxation therapy, basically self-managed pain relief strategies, referral to physical therapy, and these can help people manage pain effectively, reducing opioid reliance. So we also have a comprehensive referral pathway for enhanced support so that the peers never feel like they're the lone ranger. They can assess the severity of symptoms and facilitate appropriate referrals in addition to providing immediate support. So we want to be able to connect individuals with the necessary level of care for their specific needs. So this is something that we've been able to successfully demonstrate. When do we refer to licensed mental health counselors, psychological distress, anxiety, depression, suicidal ideation, counseling and therapy, and they can provide tailored psychotherapy and counseling as an adjunct to simply wearing the monitor and having these symptoms detected. We refer to medical providers in our agency for flare-ups of chronic pain, overdose risk, exacerbated symptoms, and then they can stabilize acute symptoms and manage medical conditions effectively. We had one person who we got an alert for, and it was for very, very low respiratory rate, like they'd almost stopped breathing, and we kept getting alerts. So it turns out this person was prescribed a CPAP mask, but refused to wear it. So we were able to capture that condition and get them back into wearing their CPAP mask. Things like that, we use medical intervention for. We can activate EMS. Fortunately, we have in our current cohort of patients, we have not had to do this, but we have an MOU with local EMS. If we detect that someone is overdosed, they're at their house, we have the precise GPS location where they are, we can summon EMS for naloxone. Direct referral to the ER, we obviously have an MOU with local emergency departments if we need to send someone there directly. And the escalation protocol is built in place. It's a safety for the PRSS, safety for the patient, and the PRSS can facilitate referrals and connect individuals with necessary resources. And this kind of promotes recovery, ensuring timely access to care. And the sweet sauce, the whole thing is based on very effective peer recovery support specialists. And I know Anna supervises them and spend a lot of time, kind of training them, what are we doing here? And so leveraging their lived experience for empathetic support, they draw from their personal journey of addiction and recovery, they establish connection with the person, and the lived experience enhances the effectiveness of the interventions. Our PRSS, when they get an alert, they conduct phone-based brief interventions. They basically are calling and saying, hey, we got an alert. I have to ask, are you thinking about using? Are you, what's going on in your life? So they utilize evidence-based techniques, encouraging positive change. They offer alternative strategies. When we are enrolling patients, we ask them beforehand, hey, what kind of things are you likely to do as an alternative strategy? Would you consider exercise, meditation, drawing, journaling, taking a hot shower, cold shower, going for a run? What are you likely to do that we could prompt you in the midst of a craving or powerful stressful episode? So that's pre-discussed, and then that's what they talk about. So they use motivational interviewing, guiding self-discovery, and basically decision-making autonomy, which is the principles of recovery capital. So the Crave Alert system relies on the compassionate intervention of the PRSS. They empower individuals to navigate crises in their life and overcome obstacles. And it's a path to recovery by providing that guided, skilled support. They guide individuals towards sustained recovery and well-being. So what are the PRSS asking the participants when they get an alert? They'll ask questions like, halt, are you hungry? Are you angry? Are you lonely? Are you tired? What's going on? And then they delve into even more specific questions. Are you experiencing flare-up of chronic pain? And they talk about pain self-management techniques. Are you experiencing anxiety or stress? And, you know, talk about how it impacts their well-being and targeted intervention, promoting relaxation and coping skills. Are you experiencing suicidal thoughts? You know, very clearly asking them. And this can help initiate an immediate intervention to ensure safety, whether that be transferred to the emergency department, calling the crisis worker, a therapist. So all of those things are built into the system. We ask about specifically, are you at risk for relapse or overdose? So we talk about the factors that could contribute to that and basically implementing preventive measures and relapse management techniques. This is kind of a snapshot of what we have. So right now we have 42 patients, 17 are male, 25 are female, average age is 40. 6 of them are justice involved currently, 13 are pregnant, postpartum, or parenting, 2 are ethnic minorities, 3 are veterans. We want to incorporate people who identify as LGBTQI+, but we have not at this point. But we're still looking to enroll that very important cohort of patients. So during our study time period, we had 209 legitimate alerts. 47 of those were for cravings for drugs. We had 6 relapses. 4 of the relapses were in the same person. 2 sleep apnea, 22 described major depression, 11 described exacerbation of chronic pain. We had 14 false positives. Some of them were humorous. One person, the peer called because they had very high heart rate, high respiratory rate, and the woman was like, "I'm having sex with my husband. Why are you bothering me?" Another one said they were cutting their grass. So different things. Another person had an alert while taking a hot shower. You can wear this device in the bath and the shower. You can swim in 3 feet of water. So that's kind of what we've received so far. This is kind of a breakdown of what we had our alerts for. On my end, on the back end, this is what we see. So we see kind of a composite index of respiratory rate, heart rate variability, heart rate. You can see this is a very stable patient compared to this one, very unstable patient. So we can see that the index is very scattered. Again, on my end and the back end, we can see a 24-hour analysis of vitals for the alert thresholds. The curved line that you see through there is kind of, it distributes this within a standard deviation. And the top person is very well adjusted and the bottom person is not. So this is kind of what we can see on the back end aggregate data for each participant. This shows a participant who started off with having the top on the left heart rate. You can see this is a relapse on stimulants, and we can see the drop in heart rate variability that preceded it in the bottom panel. And on the right side, you can see the speech recognition. They tested very high for anxiety and very high for depression. So the composite picture we get from this stream data gives us tremendous insight into our patients. On the plus side, we've had 100% PRSS response rate. Every alert triggered a response from the PRSS. They worked extremely hard. So proud of these guys. And it demonstrates our system's effectiveness in providing immediate support during critical moments. Just kind of a breakdown of the types of things. One person said when we called him, we got an alert. He said, well, I'm pissed off because I'm listening to these goddamn liberals on the radio. Then that was his reason. So that we included that as other people are having an argument. Someone said my PO just called me. So different types of things they reported. The types of strategies we used were exercise, going for a walk, refer to treatment, talk to a friend, music, prayer, take a cold shower, or dance. This is an example of things people agreed to do. And kind of the percentage of days the Crave Alert was activated for each individual. So 94% of our alerts were triggered by HRV drop more than 30%. And 6% were for HRV drop less than 30% for more than 5 minutes. Alert triggered by heart rate, 76% were for heart rate more than 120 for 5 minutes, 24% were less than 120 for 5 minutes. The average HRV drop among patients was 30%, and majority of the alerts occurred while patients were at home, emphasizing the system's potential for continuous support in familiar environments. And so we believe this is a paradigm shift in recovery management, and it can revolutionize SUD recovery management through proactive monitoring. It ensures that patients receive empathetic and tailored support and promise of enhanced outcomes. So again, very early in our pilot demonstration project, like I said, we have 42 patients. We aim to do 100 in this current cohort. That's our contact info. And I appreciate you letting me talk about this. I hope I didn't go over.
Right now, it was me that couldn't find my mouse to make it work, but that is super exciting and super and I don't know. I just like I love how all of it comes together, and of course, your background, explaining it all made it a lot easier to understand. But I don't know who has questions.
And comments. I mean, this is incredible. I mean, I've been working with a client and, he has been struggling with this, and I can only take what he says. And if this would have been in play, I might have helped him from relapsing, and that's huge. Thank you.
What does expanding this look like into other programs?
Sure. So, very good question. I forgot to mention, so this project was funded through the West Virginia Office of Drug Control Policy and Future Generations University. So that's where the funding came from. So the goal of ODCP is to scale this to all of West Virginia. Well, once we complete this successful 100 patient demonstration project, to scale it to transitional, because that's when people are at most risk, right? Like I mentioned, transition from jail to community corrections, or community corrections to home, or residential treatment to outpatient, or outpatient to home. All those times of transition are when people are most vulnerable. So the goal would be to scale this to the entire state. That is what the goal is.
Do you have a plan for quote phase 2 sort of thing yet?
So this is a good question. So we did a phase 1. So phase 1 clinical trial is on normal people. And so we were able to show efficacy and safety in phase 1. So this is kind of our phase 2 portion of the clinical trial. We anticipate doing a phase 3 at some point when we have enough data.
Okay, makes sense.
And
So
so
let's question. So phase 1 is you try something on normal people. Phase 2, you try it in people with a disease, and phase 3 is really scaling it.
So who is, I guess, Office of Drug Control Policy is paying for the monitoring and everything while it's in its trial stages?
Yes, so the Office of Drug Control Policy is paying for the devices, the monitoring, and Future Generations University is paying the peers to answer the phone, which is tremendous. I mean, they don't get paid a lot, and a lot is asked of them, and they're just amazing.
And then eventually, pitch it to funders and insurance and things like that.
Correct. There are currently CPT codes that CMS has approved. Right, Catherine Richardson, you're right about that.
Yeah.
There are CMS codes that pay for remote patient monitoring for some mental health conditions and for a lot of cardiac conditions, COPD, diabetes. So the goal ultimately would be to approach, all three Medicaid MCOs to approve the CPT codes that CMS has established for something like this. That way, there's no burden to the patient. And it would be sustainable that way, and it would pay for itself. It would, of course, require a physician prescription to get on it.
And to piggyback back on, what Catherine said about PRSS is I love that they don't feel stuck in this program, that they can elevate it to the next level to 911 or a counselor or whatever, so that they don't have that burden of guilt or anything too, that they have backup systems. So that's important to them as well.
And we did a survey of the peers. We did a survey and we asked them kind of like, how do you feel about this? And some of the comments we got back were so cool. The peers shared with us candidly that we developed such a close relationship with the clients. We know their family, we know their kids, we know where they live, we celebrate their successes. And then having an overdose, having a death is so traumatic for us because we built this relationship over so much time. So, being part of the solution to potentially mitigate that is something really important. We asked them, are you feeling burned out on a scale of 0 to 10 from getting so many alerts? Because in the beginning, while we're still working out the bugs, it was going off like crazy. It was going off. They were getting like alerts like every 5 minutes until we were able to bring everything down to right now it's working perfectly. But there was months where it was crazy. And one of them said on a scale of 9 out of 10, I'm burned out. Others said, no, I love this. I love this. So we asked them, satisfaction, do you feel you're making a difference? So overwhelmingly, they all responded that they thought it was useful, they were making a difference.
I have a question.
Yes.
So what is the future if there's funding from some source in the future? When is the longest someone could wear the Crave Alert?
I mean, again, we were talking about, so in our pilot project, we're looking for, people in those transitional re-entry type situations, right? But conceivably, somebody could wear this as long as they want. The battery life of the patch itself is 15 days. Cell phone has to be charged every 3 days. So you can replace the patches. We had a couple of people who had kind of an allergic reaction to the latex patch. So we had to replace that with a cloth non-latex patch, and that alleviated the problem. But because it's based on, again, this would be in a perfect world prescribed by a clinician like Anna or a physician or nurse practitioner. And it would be, something that could, depending on the discretion of how much progress the person is making with the therapist or physician, they could determine how long they wear it. But for our study, we've had everybody wear it 2 weeks. And our primary goal was to, capture as much data as we could, build that database, build the analytics engine so it can learn those parameters that we're teaching it, and integrate the speech recognition software into it. But yeah, someone could wear it for a year.
So if someone is in a rehabilitation facility or sober living or something, and then gets out, ideally if someone prescribed them to wear it, they could wear it for an extended period after that.
Yes, I could picture people getting out of Northwood, residential treatment program. We know that without adequate community support, people relapse. They are vulnerable to life on life's terms, all those things. So I think that's really where this is most useful. And from a payer standpoint, I think there would be interest from payers because you're reducing hospitalizations, you're reducing death, you're reducing needless redundant treatment by, detecting, so predicting it early, not letting it get to this level, predicting it here, not letting it get here is a huge advantage.
I like it because, especially in that, what we were just talking about, because that's what we see every day. People, it's easy to stay sober when you're in rehab, and then you get out and you have to deal with the stresses of life, and you can tell them to call you, but it's nice to, this is, shows when they're hitting those moments and they might be embarrassed to reach out. And I think it's a game changer.
And really if you're right, Catherine, because when you talk about embarrassed to reach out, I mean, I would never have called anybody. I would never have called anybody when I was in distress. So, and that's kind of universal, people with substance use disorders don't call out for help. Maybe they don't know who to call. They're embarrassed, there's stigma. I mean, how many times, I'm gonna ask you guys this question, because this is what really got our wheels turning. How many times do you think somebody shows up to an emergency department, signs in as a patient, gets their insurance scanned, and the triage nurse says, okay, what's going on today? Well, I've had 4 hours of drug cravings. They're going to be flabbergasted. They will not know what to do. No one ever does that. People are not showing up to the ER saying, I'm having drug cravings, or, I'm in recovery from SUD and I am having really bad anxiety right now. They're going to give you a number and say, okay, go here. There's nothing we can do for you. That's a reality of the healthcare system right now. So this is filling a gap that is, again, when we talk about reverse engineering the overdose, which is preceded by relapse, preceded by stress, anxiety, cravings, and we're intervening at this very early stage. So I think, that doesn't happen. People don't know where to go. They're not willing to go. They don't reach out for help. They've burned all bridges with their family. And so this is helping to fill that gap. I appreciate so much allowing me to present this. Again, it's very early. Hopefully, when we get everything completed, we could give you a more comprehensive overview of just the data. Thank you so much.
You're welcome. Thank you. And if you want to, I know it's still early stages and I don't know how much you want to share out, but if you want to share it to any of the other councils, we are always looking for presenters for the other councils, and I think this is important information to share out. So I can send you the days and times of the other councils, and pick some if you want to present to them, but don't feel obligated either. All right. Does anyone have anything else that they want to share, or any questions, comments? Anything going
No,
on?
I just want to say presentation.
I just wanted to let you guys get you on. So everybody that's on Subutex MAT in the jails is now asked if they want to be referred to peer recovery services. And we're getting inundated with referrals. Eastern Regional Jail referred 94 people last week, and we have one peer recovery coach to try to, not last week, last month, and we have one peer recovery coach to try to answer all of those referrals, as well as any other referrals we get from outside probation, prosecuting attorneys, public defenders. So, but it's good that they're referring them to peer recovery, but they're doing that in all of the jails in the state. So just wanted to update you on that.
Thank you. With us being on the tablets, that's slowed down a lot. And a part of it, I think, was in part that there are a lot of glitches with that app, that we were all kind of locked out of it for a while. And then it had another issue earlier this week, but I think that's resolved again. But they're starting to, which is a good thing, they're starting to share information amongst themselves, and we'll then have a direct contact. So I know, Terry, you said you've gotten a lot of referrals of, hey, I've talked to Terry, you should talk to her too. And then Heather's mentioned the same thing. So you're getting more direct one-on-one contact rather than it coming through the just the blanket email for the councils. So
We just need more funding, which nobody wants to ever give more money, but
Yeah,
Raj, maybe you can tell the Office for Drug Control Policy, the navigators need more funding, the peer recovery coaches need more funding, because honestly, you know, I'm a big advocate for peer recovery, but they're gonna talk to us about stuff that they're not gonna tell a therapist, they're not gonna tell their PO, they're gonna tell us the things, and then we can help guide them to, well, tell your PO, tell your therapist, let's get you where you need to be.
you guys are the safe space, the safe person, the person that they can connect with. So we're trying. I wrote a submission for an AmeriCorps Vista worker, so we will have one of those starting in August. And they will, that was part of the qualifications for this person is they have to have lived experience. So we'll have one of those starting in Logan in August. Still waiting to hear from the Appalachian Regional Commission grant. That would give us 3 more navigators. And all of it is just, to build data to show that this is a billable model and, how can we become billable as navigators like the PRSSs are billable.
We're getting there.
I know.
Think about where we were 5 years ago.
Yep.
Just slow.
Yep, exactly.
Thanks, everybody.
Yeah.
thank
All right.
you.
Well, I'm sorry, what, Terry?
I just said thank you.
All right. Well, again, thank you to everyone for showing up today. I know we were a week delayed because of the holiday, but thanks for taking time out of your day, and we'll see you again, I guess, next month. So, or sometime I'll see you this afternoon in the next meeting. Bye, everyone. Thank you.
Thank you all.
Bye.
Thank you, Raj.